Good morning, good afternoon, good evening to all of you joining us today. Thanks very much to the journalists joining us online. I'm going to come shortly to your questions, both live and those sent to us in advance. This week we're looking at the issue of post-COVID conditions, commonly referred to as long COVID. A slightly different format. We'll be going to the regional director, sat here to my left shortly, and then we're very grateful to be joined by Mr. Richard Rools, a member of the Technical Advisory Group on Mental Health impacts of COVID-19 in the WHO European region. Richard will be sharing some of his personal experiences of living with long COVID. It's then an honor for us to also introduce Professor Martin McKee from the European Observatory on Health Systems and Policies. Professor McKee is the lead author of the policy brief in the wake of the pandemic, Preparing for Long COVID, that is published today. And he will be explaining some of the findings and insights from this policy brief with us. So I welcome those two gentlemen also to join the panel, which will also include this week, as always, our Dr. Catherine Smallwood, the COVID-19 Incident Manager in the WHO Health Emergencies Programme here at the WHO European Office, and Dr. Siddhartha Datta, the WHO Regional Advisor on Vaccine Preventable Diseases and Immunization. We're also joined on the panel today by Dr. Dina Pfeifer, Focal Point for Clinical Management on COVID-19 from the WHO Emergencies Programme, Health Emergencies Programme, excuse me. So without further delay, I will pass the floor to the Regional Director.
Thank you, Rob. Good morning, everyone. To date, close to 38 million cases of COVID-19 have been reported in the WHO European region, as well as 850,000 deaths. The SARS-CoV-2 virus continues to spread at very high rates across Europe, with two variants of concern continuing to displace other variants, increasing their reach and challenging us to continue to do more. For the second consecutive week, less than 1 million new cases were reported as transmission continues to slow across the region. The decrease in new cases in the past month is driven by countries that have implemented new measures to slow transmission. New reported cases have declined by almost a half since the end of 2020. However, to put that into perspective, the number of new cases in the region now is 10 times higher than in May last year. And it is still the case that across the region, most countries have very high or high levels of community transmission. I know that many of you are eagerly awaiting a return to a new normal, where we are no longer restricted by measures limiting our freedom and the transmission of a deadly virus. Others, a significant proportion of those who have survived COVID-19, are asking when and whether their health will be fully restored. These are the many thousands who are experiencing post-COVID conditions, also referred to as long COVID or post-COVID syndrome. Today, we shed light on the fact that in some patients, the disability following SARS-CoV-2 infection lingers on for months with severe social, economic, health and occupational consequences. The burden is real and it is significant. About 1 in 10 COVID-19 sufferers remain unwell after 12 weeks and many for much longer. As with any new disease, so much was and remains unknown. As the pandemic has evolved, professionals and patients alike have mapped a path in the dark through their experiences. Yet, stories of those who should have recovered, but whose lives were still affected by debilitating symptoms soon emerged. Regrettably, some were met with disbelief or lack of understanding. We need to listen and we need to understand. The sufferers of post-COVID conditions need to be heard if we are to understand the long-term consequences and recovery from COVID-19. It's a clear priority for WHO and of the utmost importance. It should be for every health authority. We do not have all the answers. We do not yet know what percentage of patients have these longer-term effects, but we're learning fast. Earlier this month, WHO hosted a consultation on post-COVID-19 conditions, focusing on recognition, research and rehabilitation. As we learn more, we need to make sure patients who have had suspected or confirmed COVID-19, who have persistent, new or changing symptoms, should have access to follow-up care. This is where primary healthcare has a particularly strong role to play. Today, we complement guidance we have published with a new resource for decision makers on what we know about the condition and available responses and policy. Professor Martin McKee from the European Observatory and the London School of Hygiene and Tropical Medicine will shortly speak on this. I am calling upon you, countries and institutions in the European region, to come together as part of an integrated research agenda, using harmonized data collection tools and study protocols. This will be key to maximize the impact of treatment and improve longer-term outcomes for patients. As a next step, I will be convening the chief medical officers of all 53 countries in the European region to set out a regional strategy to meet this goal. A crucial part of this is listening to those who are experiencing post-COVID-19 conditions. With us today, speaking from the UK, is Richard Rools, who had COVID-19 in March last year. Richard, thank you so much for joining us.
Thank you.
Could you please tell us about your journey? And secondly, how are you doing today, 11 months on?
Thank you, and thank you for the opportunity to speak. I think I'd like to start my answer to that by focusing on my life before March 2020. And I have to say it was really, really good. I was 42 years old, a proud dad. I was running a successful company as an occupational psychologist. I used to swim regularly. I just finished building rear extension to the rear of our house. I'd say I was probably in pretty good health. And then what? Well, in early March, I developed a little tickle in my throat, which soon developed into the classic COVID-19 symptoms of a cough, fatigue, loss of smell. My heart was racing. I went into our loft to isolate for a week and came back down feeling pretty groggy and pretty rough, to be honest. And some 10 days later, all those symptoms came back again and I crashed badly. This wasn't supposed to happen. It wasn't in the descriptions we had of the illness. I had no idea really what was going on, and neither did my GP. It was quite a scary time. I recorded messages for my wife and daughter and wrote them letters. I feared that the worst would happen. But I kept waking up. I was left with fatigue and a head that felt like it was pumped up like a balloon. And that episode marked the start of what I'm calling my corona coaster journey. Summer and autumn was a horrible time. I kept being hit by new waves of symptoms. I lost sensation one day on my right-hand side and was sent to a hospital for a scan to see whether I'd developed a stroke. And the day my feet went purple, I was again sent to the hospital to check whether I'd developed a clot in my legs. I'd say the healthcare I received at the time was good at investigating the immediate problems, but it all felt so reactive. There were periods where I just shook uncontrollably on my bed. I was so exhausted and I was just unable to sleep. I spent a lot of my time hunting for information, trying to find out what was out there. In the early days, it was very, very little and it was quite bewildering. I was advised to do graded exercise therapy to help my body recover its strength. This is a therapy where over a period of days you gradually increase the amount of exercise you do. But unfortunately, it's led me to crash again. One day I was walking along and ended up having to lie down by the side of the road, raising my feet in the air just to recover so that I could make my way back home. I really regret following that advice. I've tried several times returning to work at that time. It was just too early to work in a way that I would call kind of competent at a level that I would be happy with. I couldn't even walk to a local park for family get-togethers and ended up having to get a taxi just 5 minutes up the road. I think it's the symptoms all on top of each other that just make it a really horrible experience. if someone asks me what it feels like, the only thing I can really describe it as is it's like a combination of your worst ever hangover and concussion. And it's the toll on the people around you too, my family. Now, I'm told I'm not the same person, and I know that's true. It's just a really difficult thing to come to terms with. Over the winter, I did try and get on top of things. I started using techniques that I developed with my help from a cognitive behavioural therapist about using my energy sparingly, about pacing myself and prioritising my time. I started limiting the amount of exercise I did, and I started getting more active in the long COVID community and the excellent work of long COVID support, which is a Facebook group with now, unfortunately, 36,000 members in 99 countries. The biggest issue I have now, well, it's fatigue, brain fog. My breathing's still quite erratic. I have to take breaths as I go. My legs feel very, very heavy still. My feet and hands just with something going on where they're flaring up every evening in bright reds, which I'm starting to get checked out. Just over the weekend, I went for a walk with a family, and much earlier than I would expect, my legs again seized up, and I ended up lying down in the car park this time, and ended up calling a taxi to get me back home. I think one of the hardest things is just people not believing you, telling you just to get on with it. Long COVID denial is something that exists for me, I think, at all levels of society. It includes some of my friends, GPs I've spoken to, right up to the top levels of our decision makers. Long COVID has massive implications for employment, mental health, our economy. It impacts every part of your body and your whole life. Cases of long COVID must be counted, researched and recognised. People need rehabilitation. And I know there's a lot of journalists on, and you've heard a bit about my story, but there are so many stories out there, and I really recommend, if you want some experience from people in your own country, if you go to longcovid.org, resources and patients, there's a PDF document in there of support groups which have got contact details for people in your country, or you can email info@longcovid.org. And many of their stories are unfortunately much worse than mine. The WHO long COVID policy document is a significant call to action, emphasising patient involvement must be at the centre of the action that must follow. It's an excellent document, but that policy must reach patients, must be translated into action. We have it all saying in the long COVID community, which is nothing about us without us. Thank you.
Well said, and thank you very much indeed, Richard, from all of us, for being with us today, for sharing your experience and experiences with your Corona coaster journey, as you put it, so very openly with us. Very much appreciative of that. It's clear that health impacts that some people experience following COVID-19 really warrant and require further understanding and support. So we're very grateful that you've shone a light on this from your perspective today. Thank you. Now let me turn to Professor Martin McKee to tell us more about the findings and policy implications in the policy brief that is published today. Professor McKee, the floor is yours.
Thanks, Rob. Thanks, Hans. And particularly thank you to Richard for that very powerful testimony. So over the past year, we've all been getting very used to watching the daily toll of cases and deaths from COVID as they rise and fall. We see them on our television screens every evening. But I think we now know that this is only one partial picture of the pandemic. As Richard has said, from the very earliest of days, we've been hearing from people who've had COVID, but instead of making the full recovery that they would have expected, they've continued to suffer, and sometimes for months, sometimes many months. Now, we probably should have expected this, although many viral infections are self-limiting, making people feel unwell only for a few days before clearing up. We know that some cause long-term problems. Early on, we realized that this was a particularly unpleasant infection. This new coronavirus was not just causing pneumonia. In some patients, it was attacking many body systems, the heart, the blood vessels, the brain, the kidneys, and others. Now, inevitably, at the beginning, our efforts concentrated on saving the lives of the tens of thousands of people who were most severely ill. We all saw the images on our screens, particularly from Lombardy in Italy, but then progressively from elsewhere. And it took some time before we turned our attention to those who were suffering persisting problems. In fact, we owe a debt to those who were suffering from those patients, like Richard, who came together to raise awareness of this condition. And as a consequence, we now know a lot more about the condition that we call long COVID. Long COVID, the name given to it for the patients who were suffering from it. We know that about a quarter of people who've had the virus experience symptoms that continue for at least a month. And as the regional director has said, about 1 in 10 are still unwell after 12 weeks. And with the passage of time, as Richard has reminded us, many are suffering for much longer. Now, you've heard how this is a condition that can be extremely debilitating. Those suffering from it describe a varying combination of overlapping symptoms: chest pain, muscle pain, fatigue, shortness of breath, and what patients describe as brain fog, among many, many others. We are, at last, beginning to understand why people get these symptoms. They include persistence of the virus in some parts of the body that are sheltered from the immune system, such as the brain. They include direct damage to organs, such as the heart and lungs, and also to the pancreas, causing some new cases of type 1 diabetes. And then from blood clotting, the hypercoagulability associated with the virus, which can cause heart attacks and strokes. But there's a huge variety in both the pattern of symptoms and their severity. One of the most important things that we have learned about this condition is that the likelihood of getting long COVID does not seem to be associated with the severity of the initial infection. Some people with very mild symptoms at the onset still get it. But there are some people who we know are at greater risk, including women. And even though we know that they are less likely to die from COVID, and also health workers seem to be at particular risk for reasons we're not altogether sure about. Now, obviously, this is a condition that can have a huge impact on people's lives. Many people are unable to return to work or to have a social life. Many people have described how it impacts on their mental health, especially because the course of this condition is often fluctuating. And as you've heard from Richard, often they feel that just as they're getting better, either new symptoms or the old symptoms come back again. And of course, it has huge economic implications, not just for them, their families, but also for society. So we've published this new policy brief to raise awareness of the condition. We hope that it will help those who are responsible for health services to appreciate the complexity of long COVID and to give them up-to-date information about it. But of course, recognizing that the evidence is changing. And in fact, we were revising the document right up until the minute it went to press. So what needs to happen now? Well, we are calling for multidisciplinary, multi-specialty approaches to assessment and management. This is not something that can be dealt with by clinicians from any one specialty, by people with any one set of skills, by people with any one set of diagnostic tools. We need people to come together to work in teams. And that is a real challenge in many countries because of the way that health systems are organized. As Richard has said, we need to work with patients and their families to develop new care pathways. We need to listen. We need rehabilitation. We need online support tools. We need to see patients as partners in the recovery. And I mean as partners. This means working together. And that may mean new ways of thinking by both health professionals and by patients. Because unfortunately, we have seen too many times in the past when chronic conditions have seen a fragmentation into them and us, and that's not going to help anybody. We need to look at employment rights. We need to look at sick pay policies. We need to look at benefit packages for those affected. But above all, we need much more research with patients fully involved in deciding what questions to ask and how we're going to answer them. Thanks very much.
Thank you very much, Martin. Now let's turn to the journalists that are calling in. I'm first going to go over to Esme Miralevic from N1 Bosnia-Herzegovina. Esme, can you hear us? Can you go ahead with your question?
Yes, I can hear you. Can you hear me?
Yes, we can, please.
Okay, the question is for all. Maybe Dr. Kluge will be the best to answer this, but we are having here a situation in the region that the very low number of vaccines have arrived. In Bosnia and Herzegovina, less than 5,000 vaccines have arrived so far. So how this slow rollout can impact our fight against COVID, and could this prolong this situation? Because here we are having bickering between government and COVAX, who's responsible for not delivering vaccines and all what is going on. So how this will have the greatest impact on us? Thank you.
Please, Regional Director.
Thanks, Esmir. And I can assure you that the teams are 24/7 on this particular issue, not only for Bosnia-Herzegovina. In fact, we invited the ambassador of Bosnia-Herzegovina a week and a half ago to the UN city here to discuss the situation. The COVAX is now starting up. It may take a little time to really be fully operational, but we're also working closely, for example, with the European Commission at all levels on the issue of donations, in this case to the Balkan, with Austria being the coordinator for those donations, and also assisting the countries to make the bridge to that one. But you're absolutely right. It's a combination of what needs to be done. First one, really to scale up the vaccination rollout. And there are production issues, production capacities. And there we're also trying to assist to identify production sites which could help to beef that one up, is number one. Number two, even with vaccination, Esmir, that's a very important message. The vaccination is very, very important. But it will not turn over the battle alone. So continuous attention and investment in public health, social, behavioral measures, it's very important, not at least because of the speed with which the different variants are raging in the region. And then the third one is to continuously to strengthen the health system with the testing, isolation, contact tracing, and quarantine. So it's an issue of timing. And I agree with you, speed is our best friend here.
Thanks very much, Regional Director. Siddhartha Datta, would you like to add anything just briefly to what the Regional Director said?
Yeah, thank you so much, Rob. And just continuing from what Regional Director has eloquently mentioned, I think the issue is, as you have correctly raised the point that the demand for vaccine and the available vaccine volumes, which was identified quite earlier in several of the press conference, our Regional Director has always mentioned that this is the pace of vaccine demand and the supply is not commensurate. And that is an effort made by the COVAX to ensure that countries without any, irrespective of their income level, get access to this vaccine. And hence we see this entire allocation mechanism happening within the COVAX. We have seen the good news of vaccines being delivered through COVAX to Ghana, and I think that process is just a start. And the rest of the issues the Regional Director has eloquently mentioned. Thank you so much.
Thank you very much, Regional Director. Thank you very much, Siddhartha. Next, I'm going to go over to Konstantinos Davanis from Hellenic Public TV, ERT, Greece. Can you hear us, Konstantinos?
Yes. Can you hear me?
I can, please.
Hello. Thank you for taking my question. We're here today about the long COVID complications that affect many vital organs of the body after the recovery. Is there a clearer picture today of what are the most common long-term complications of the coronavirus? Are these complications related to age, severity of the disease, or the patient's health status? And the second question, we have been hearing for the last few days about new mutations that are causing concern. Mutations of the virus have been reported in California, in the United Kingdom and Nigeria, and in Finland and Alsace. Can you please give us more clear information? Do these mutations concern you, or is it a sign that the virus is losing its power? Thank you very much.
Great, thank you very much, Konstantinos. We're going to go, so long COVID, I'm going to go over to Professor Martin McKee first, and then to add, if Dr. Dina Pfeifer would like to add any points to Martin's points. And then on the new mutations variants, I will go to Katie Smallwood, Dr. Katie Smallwood. So yes, please, Martin, on the first question.
Thanks. I mean, there is some suggestion, particularly from the Zoe work from King's College London and elsewhere, that there may be clustering of types of symptoms. So people who've got predominantly respiratory symptoms and then people who've got other body symptoms. But I think as we're learning more about this, essentially, it probably is not the right way to look at particular clusters or packages, because it really does depend on how the individual has responded to the initial infection. To what extent have they suffered from the direct damage by the virus to, as I say, the brain, the heart, and the pancreas, and so on? To what extent is it blood clotting? And with all of these different these different mechanisms involved, I think what we will see is just a myriad, a variety of symptoms. And I think over time, we'll get a much better idea of which of them was common. Fatigue is pretty constant, actually. Fatigue, brain fog are some of them are very common. But I think that we're still quite early in understanding the whole spectrum, not least because many of the studies we have are not entirely representative. They are all sampled from groups in one way or another.
And Dr. Dina Pfeifer, would you like to add anything to what Martin's said there?
Maybe for better understanding what is underlying problem within COVID is the inflammation of inner layer of vessels. And this means it can affect any organ system. And this explains to some extent why we have this large variety of symptoms. So it's not really that much about what's the most frequent one and is it more frequent in one group or the other. In theory, it can be really a very large sort of scale of different symptoms. Having a good understanding of underlying immunological and pathophysiological processes would give us then, or open the field for trying either to diagnose them correctly and as well to start testing various treatment interventions in order to assist the people with their complaints.
Thanks very much, Dina. Katie, on the question regarding variants, please.
Thank you very much, Konstantinos, for the question. And let me just provide a very brief summary, but further information can be obtained from WHO through our various resources online. So as you rightly said, there are several new variants of SARS-CoV-2 that are circulating in the European region. Viruses, especially RNA-based viruses, do evolve naturally, and we do expect to see mutations arise. And we do expect to see variants arise. The more infections there are in the human population, the more new variants of SARS-CoV-2 will arise over time. Now, the point is that, yes, some of these new variants are of particular concern. And there are several variants of concern that are spreading in the European region and are spreading with increasing geographic spread and reflecting an increasing prevalence among the different variants circulating. One of these was identified in the United Kingdom in December. We call it B117. And that particular variant has indeed shown both increased transmissibility, i.e. it transmits better between us as humans, and it is now showing, based on some new evidence that has been emerging over the past month, increased rates of hospitalizations. So it is seemingly both better at spreading between us, and it is conferring more severe disease in some of our populations. That virus, that particular variant of the SARS-CoV virus, is being spread in approximately half of the European member states across our region. But more than that, more than half of the countries have actually reported cases to us, and that's continuing to increase. So yes, they are of concern. These variants of concern do respond to the same measures, but they will require us to rethink our strategies, to up the ante and to respond a little bit better in order to be able to control them. Thank you very much.
Thank you very much, Katie. I'm next going to go to one more. I'm next going to go to the one more live journalist before. Journalist joining us live, I should have said. Before I go to some of the questions that were sent in advance. So Tatiana Sultanova from Newsmaker Moldova. Tatiana, please, your question.
Good afternoon. Thank you for this opportunity to ask a question. Do you hear me?
Yes, we do. Please go ahead.
Thank you. I would like to ask how much in Europe increased mortality in 2020 compared to 2019, and how badly has the coronavirus affected this? And has Europe faced the increase in death among people with chronic diseases who were not infected with COVID due to the fact that people with chronic diseases received less attention from doctors during the pandemic? Thank you.
Thank you. Well, I'll go to the regional director first and then over to Katie Smallwood.
Thank you, Tatiana. You're touching upon the main policy issue faced by all public health leaders. We call it the dual-track health system response. How much attention to the COVID-19 and how much to the other diseases? Our viewpoint has been clear since the beginning. The WHO Constitution is about attaining the highest possible level of health for everyone. It is not about the lowest possible level of COVID-19. That's why a couple of weeks ago we launched the pan-European movement United Action Against Cancer. 1 out of 3 people in West Europe, 1 out of 4 people in East Europe will develop some form of cancer, while you're absolutely right, in many countries, in fact 9 out of 10 countries, essential health service has been disrupted, and that is across the board, not at least on the mental health. On the specifics up, maybe we can go over to our specialists.
Please, I'll go over to Katie and then I might invite Professor McKee if he'd like to say a few words to this question as well.
Thank you very much, Rob, and thank you for the question. So over the course of the pandemic, due to COVID-19, as the regional director announced in his statement, we've seen close to 850,000 deaths due to COVID-19. Of course, those don't represent all of the deaths due to the disease because many deaths remain uncounted. And that does not include the increased mortality due to secondary consequences of the pandemic itself, which are significant. What we use to measure this in the European region is excess mortality. And we do have a network of countries that report to us the number of excess all-cause deaths. So this is deaths that are registered for all causes. And during the course of 2019, what we have seen is a very significant increase in excess mortality in those 20 countries that have been reporting through the Euromomo mortality network. It's difficult to give a very precise number for the whole of the European region because we don't have that data from all of those countries. And the other thing that we have to bear in mind is that the effects in terms of both disease and deaths in the populations because of COVID-19 will continue to occur in a much longer time frame. Some of these chronic diseases, for example, that may have not been detected early enough during the pandemic or may have suffered by the fact that essential health services have been disrupted, the impact of those may only be seen in the coming years. So this is something that we're going to have to track over time very closely to really understand the broader impact of COVID-19 on our populations.
Professor McKee, would you like to add anything to...
Well, maybe just to add that I think we all know that the restrictions have been absolutely essential. Otherwise, we would have had even more deaths from COVID. And we've seen every time in many countries when we lift them, then you get an upsurge in infections and obviously deaths as a consequence of that. And I think what that does is it highlights the importance looking forward of preparation and planning to ensure that health systems are resilient, because we will have another pandemic, and look at whether or not we have enough capacity, we have enough preparations in place. It's not that we can somehow or other get rid of lockdowns and restrictions, as some people argue. We absolutely cannot, because then our hospitals will be completely overwhelmed by COVID. It's a matter of putting in place those mitigating measures with preparedness and investment for the future.
Very good. Thank you very much. Next, I'm going to go to Thomas Berding from the German outlet RTL. Thomas, please go ahead. Thomas Berding, can you hear us? You have your hands raised in the system. No, it doesn't look as...
You hear us? You hear me now?
Yes, I do. Please go ahead.
Yeah, first of all, greetings from Berlin. I have a general question to Mr. Kluge. You recently said in an interview with the Danish TV that the worst scenarios are behind us and that the pandemic will over in a few months. Can you please tell us why you're so optimistic?
Yes, thank you. I appreciate the question, because I think that there's something to be corrected there. What I told is first and foremost that no one can predict the course of the pandemic. So that was the first part of the statement. That as a working assumption, I would take that at the beginning of 2022, we may be done with the pandemic, with a lot of disruptive interventions, but the virus will still not be at bay. And third, that this really depends on our individual and collective behaviors, as Professor Martin McKee also was pointing out, that the public health measures need to be adhered to. When I told that the worst is behind us, what I meant is that 2020 was terra incognita. We had political darkness, scientific unknowns. But I did not state that it will be done in a couple of months, because that's something that no one can predict. Thank you.
Thank you, Thomas. And also thanks to Irina Dergacheva from TASS, a correspondent for the Nordic countries, who asked a related question. So, Irina, I think the regional director has responded to that question that you submitted in advance. I'm next going to go back to long COVID and a question for Professor McKee from Robin Cooper, a freelancer in the UK, who's not with us, but we have some questions that have been sent in advance, and this is one of them. Is there a link between long COVID and an increase in mental health conditions? I think you partly answered this with your statement, but Professor McKee, if you'd like to elaborate.
Well, I suppose the answer is partially, because clearly long COVID can give rise to mental health problems, particularly because of the uncertainty. That's one of the key problems with everything about the pandemic. It is the uncertainty, the unpredictability, but in this case, it's the uncertainty about whether the symptoms will go away or will they come back again. But of course, obviously, the mental health implications of COVID are much wider than this, and they arise for all sorts of reasons. In particular, because of the challenges of isolation, in particular. But I would really add to that and say it's not just the isolation; it's our failures to provide support for people who are isolated, and to provide that degree of support, and to recognise that a comprehensive response will look at all of those issues. We need the restrictions to stop the spread of the virus, but we also need to accompany them by all sorts of measures to minimise their impacts on people's health.
Thanks, Professor McKee. And we've got a second question here from Robin, which I think, again, you've expanded on previously, but maybe if you want to add a little more. What are the most effective ways to manage long COVID? Is there sufficient support out there for sufferers?
Well, I think that's what our report is all about, trying to encourage. I think that we are hearing from patients that often their problems are not being taken as seriously as they might be. We need to have those proper multidisciplinary, multi-specialty teams who can do a comprehensive assessment, because the manifestations are so diverse. But we also need to recognise that we need to get it right, because there will be people who have many of these symptoms who do not have long COVID. And it's going to be quite a difficult challenge to differentiate all of that. I think, and we don't have all the answers on that. But it's we need to take this very seriously, and we need to look at doing this in a proper scientific way, but working very much with patients to understand the challenges that they're facing.
Thanks very much, Professor McKee. I'm next going to a lot of questions I can see on vaccination that we received last week as well. Judith Sanyansky, Club Radio Hungary. This question's for Siddhartha, I believe. Hungary has started to vaccinate people, mostly elders, with the Russian and Chinese vaccines. The majority of the population is very skeptical about these vaccines, not certified by any international body. Is the Hungarian government right in doing so? And what is your position on this? Siddhartha Datta, please.
Thank you, Rob. Thank you, Judith, for that question. So let me try to answer your question in two parts, as the question had several elements. One is every member state in the WHO European region or globally are sovereign to decide on the use of a vaccine. And I think we need to start acknowledging it that vaccines, irrespective of the origin of the country, need to adhere to the principles of safety, efficacy, and quality. It doesn't matter which country is producing it. WHO has laid out the different parameters which need to be looked into by the national regulatory authority of every country to ascertain that the vaccine is safe and efficacious. In that regard, it's extremely important that we remember that the country, as I have mentioned, will be able to make a decision. And I think this also applies to Hungary and also for other countries. The next part of your question, whether the population is skeptical, I think it's extremely important that we underline that vaccine is one of the tools that is available with us to bring an end to this pandemic. Vaccination, the trust needs to be instilled in the community for all the vaccines that are available, and this transparency in sharing the information on decision-making process in a country and the vaccine characteristics need to be done proactively by all the governments and the member states. The other part of this vaccines and vaccination, you have heard from our regional director earlier that the more robustness in the preparedness in the vaccine rollout in a country, which also mean that the communications around this vaccination is being done to the people who are receiving the vaccine. Why a particular group in a country is receiving and not the others there has to be a need in the country to make it much more clearer to the population group so that they don't feel either privileged or not privileged in receiving the vaccine. So this entirety of this vaccination need to be considered in any country while the vaccine rollout happens. Thank you so much.
Thanks very much, Siddhartha, and thanks for the question, Judith. Next, I'm going over to Konstantin Ionateshvili from iPress Georgia. Konstantin, please. Konstantin, do you hear us? Yes, please go ahead. We hear you.
Thank you. At the moment, Georgia is the only country in South Caucasus which has not started or not bought the vaccine yet. Armenia has bought Russian Sputnik vaccine. Azerbaijan, with the help from Turkey, has bought Chinese vaccine. For the Georgia, neither of these options is good. Buying a Russian vaccine is completely unacceptable because Russia still occupies 20% of our territory. Because of this situation, it's critical for us to receive European or US manufactured vaccines. Can WHO, through COVAX platform, consider this for the future and provide Georgia with European vaccines? What do you think about it? Thank you.
Thanks, Konstantin. I'll go to the regional director and then to Siddhartha Datta.
Thank you, Konstantin. And that was exactly the reason why before Christmas, before New Year, I went myself on the country visit to Georgia, met with the president, the then prime minister, of course, minister of health, and the different colleagues to work together on the introduction of this vaccination plan. As Dr. Siddhartha Datta was telling, so the COVAX did deliver already its first delivery. In fact, 1 week after WHO emergency use listing, so that's quite fast, but of course is not enough. So plans are being worked out. I know that the Georgian government is working very, very hard, including with vaccines which are emergency use listed. But again, it's a matter of timing. And I understand that each day counts. But I'm quite optimistic that soon the results will come for Georgia.
Siddhartha, please. Any points to add?
Yeah, thank you so much, Rob. And thank you for that question, Konstantin. So I think we need to acknowledge the commitment of the government of Georgia and the Ministry of Health to join the COVAX, an unprecedented mechanism put together by WHO, Gavi, and CEPI to ensure that vaccines of assured quality is being provided to countries irrespective of their income level. We do appreciate that and we acknowledge it. Moving forward is what the regional director mentioned. One of the principal aim of COVAX is to ensure that the countries who are participating get assured access to portfolio of vaccines. This portfolio of vaccines they go through the process of emergency use listing, ensuring that WHO and other stringent regulatory authorities have looked into the quality, efficacy, and safety of these vaccines. So I think it's not a matter, as I have mentioned earlier as well, country of origin of the vaccine. What it matters is whether the vaccine is safe and efficacious to use, because ultimately at the end, it is the people who need to get the benefit from the existing vaccines. And I think this will instill this entire process of ensuring there is a thorough review of the vaccine's efficacy and safety will instill the trust which is needed at this point of time for the population groups who are receiving it. Thank you.
Thanks very much. Okay, so next I'm going to go over to Naomi O'Leary from the Irish Times. Naomi, please.
Thank you so much for taking my question. It's about vaccine strategy and how vaccine strategy could have an impact on the emergence of variants. Are there better and worse strategies in terms of preventing the emergence of variants? Thank you.
So I think I'm going to go first to Katie and then Siddhartha, and maybe invite Professor McKee also to add to their statements. But Katie, we'll start with you.
Thanks very much for the question. And the best strategy to mitigate the emergence of variants and to control them is to really suppress the transmission of the virus. And Ireland has done that very significantly over the past month or so, with some quite restrictive measures brought in place after Christmas and in the new year. Cases have really come down in Ireland. This needs to happen in all countries across the European region, and then we need to sustain those case numbers as being low. The more we can suppress the transmission of the virus at the European and at the global level, the less likely it is that new variants will emerge. But also, the fewer cases that are occurring in our communities, the easier it will be to respond quickly when new variants do emerge. And they will spread before we really have a handle on assessing how they have changed in terms of their characteristics and disease transmission, severity, or whether they are going to impact any of our medical countermeasures such as vaccines. So we really need to get a handle on transmission. In terms of the vaccines, I'll let my colleague Siddhartha say a little bit more, but just a little bit on the effectiveness of vaccines in the sort of variant context. We do see efficacious vaccines, and we should continue to use them. They are one of those tools that form part of the wide range of measures we have, and we don't need to go over what those are again, but they will help in driving deaths down, and they will also help in driving transmission down based on the recent evidence from AstraZeneca and the Pfizer vaccines in countries like the UK and Israel. So over to you, Siddhartha.
Yeah, thank you, Katie. So Thank you, Naomi, for asking that question. And in terms of the vaccination strategy, what is extremely critical that we ensure that the vaccine in its current form, as we know, does two things. It is designed to reduce the severity of the disease and prevent deaths. And all the national vaccination strategies at this point of time, as we see, are targeting two principal groups. One is our health and social care workers, who are the primary front line in the COVID-19 pandemic. And the second are individuals or elderly people who are more than 65. And these vaccination strategies are designed to ensure that the vaccine characteristic for which it is being designed for is the population gets benefited. But I think the other element which I want to also bring here in line with what Katie just mentioned, there is a need to understand the variants better. There is also a need to understand how the current vaccines behave with the variants. We are understanding these two different aspects more with every day that we are walking. The research and development which will be needed in this changing environment is also critical. The good part of it is the current vaccines, the different vaccine technology platforms that we have used to develop this COVID-19 vaccine allows us to undertake those nuanced, different new research and technologies to see that the current vaccines or a new version of the vaccine could work for the variants which will come, and then we'll see how quickly these changes can be tweaked and the new vaccines can be developed. But until that time, I think that we need to understand and keep in mind that vaccine in itself is not a silver bullet to take care of, to bring this pandemic in control. There are other different measures tested, which the public health measures need to continue, and the vaccine should be seen as an added tool in this toolbox. Thank you so much.
Thank you. Professor McKee, any additional?
Yeah, well, first of all, I obviously completely agree with what's been said, but I think two things that we need to really stress. There are people who are saying that once we have vaccinated those people who are most at risk of severe illness and dying, that we could open up economies and open up society. What we should be absolutely clear about is that will simply encourage the emergence of more dangerous variants. Viruses only mutate when they replicate. And we've already seen that the places that the variants have come from have been the places with the high levels of community transmission. We haven't had a variant emerging from New Zealand or Australia or Vietnam. So it's absolutely crucial we get that message across, given that there are quite loud and vocal voices calling for opening up everything because the vaccine will save us. The other thing that I think we need to stress absolutely is that many countries really need to step up their sequencing so that we can detect early the emergence of variants. Unfortunately, within the European region, only a small number of countries really are doing that. Many others could do it perfectly easily. They have the resources. They're large, wealthy countries, but they're not doing it. And I think that is a really high priority now.
Thank you, Professor McKee. Siddhartha just referred to carers as a priority group for vaccination, which provides me with a good bridge to Tom Magner from Carers World Live. Tom,
thank you very much indeed, Rob. I appreciate the segue. I've got a question this morning about long COVID. Taking into account the present knowledge of the variants of concern, what effect, if any, do the current vaccines have on long COVID? And linked to that, and this is a particular issue for unpaid carers, what proactive services should frontline hospitals now offer to treat the serious effects that your contributor, Richard Rolls, has so clearly described? I presume it starts with actually believing what the patient says. Thank you very much.
Great. I'll pass that straight over to Professor McKee to comment on.
Sorry, I didn't quite hear the first bit just because there was
It's the effect on vaccines on long COVID.
Yeah, sure. So at one level we could say we don't know, but at the other level we could say, well, what the vaccines are doing is preventing people getting severely ill and dying. So therefore, that is very likely to limit the amount of damage to the blood vessels that was described earlier, the cytokine storms, the inflammatory response. So we would expect that the vaccines will significantly reduce the risks of those parts of long COVID that are mediated by those mechanisms. But I think we still need to wait to hear. And then in terms of the services that should be provided, I think I should ask Richard, actually, because I think I shouldn't be hypocritical here. We should be asking the patients to say what they think should be provided. We've set out some ideas in the policy brief, which are based on listening to patients, but it's better to hear directly.
Absolutely. Richard, please.
Sorry, can you just refresh? We're talking about the prospect of vaccines for people with long COVID.
I think
and
really
the
what
priority.
services should we be providing? What services would you like to see? What people in your situation?
Okay, I think in the UK we've seen announcements for long COVID clinics, and ultimately those clinics were announced at a time when I don't think that there was the resourcing was allocated particularly strongly for them. I think that's the ultimate goal to be looking for, is to get those long COVID clinics up and properly resourced.
Clear. Thank you. Thanks very much, Richard. And I'm just going to invite Dr. Dina Pfeifer, who's also with us on the panel today, if she would like to add any points here.
Yes, I would. I mean, you've heard quite a number of times that we actually don't know enough to provide a good service or to address the needs of the patient. And it's so important that we integrate the research agenda into the clinical service, because only by looking into what are the concerns, testing in an appropriate way, interventions, and by interventions, I mean, it can be a diagnostic pathway as much as trying some therapeutic or rehabilitation type interventions. We can't highlight sufficiently the need for rehabilitation. We've mentioned just a couple of moments ago about mental health impact on the patients. And certainly there are methods that those who are working on rehabilitation can recommend already now without knowing all the details, but can sort of support the patient. Obviously, as we heard from Richard, sometimes the advice doesn't work well in individual situations. So there is a learning path, and that is exactly why the research agenda is so important. We do have countries that have this ability already built into the clinical service. United Kingdom with its GPRD database is one of them. It's very easy to follow up and do operational research, and we would certainly be calling onto the countries to consider the ways of integrating research with clinical service delivery. It's going to benefit to the patients first and foremost, but also to the health system to ultimately deliver an effective services to its population.
Thank you very much, Dina. I've got time for one more question, so I'm going to go over to the Observer Times of India. Ashvin Bashinge. Ashvin, please.
Thank you for considering my question. As mRNA vaccines are a new type of vaccines in which part of the coronavirus genetic code is injected into the body. Albeit current studies of the report, there is no success being used in the population. What reports WHO Europe have on traditional method used for development of corona VAC vaccine? Is it an inactive vaccine? Can we enlistment coronavac in emergency sanctions? Thank you.
Thank you. I pass that question on to Siddhartha Datta to respond to. Thank you, Ashvin.
Thank you, Rob. Thank you, Ashwin, for that question. There was some breakage between the entire, when you were asking the question. I will try to answer the portions that I understood it correctly, and happy to take the questions later if you feel that I have missed out some part. So in terms of the vaccine, let me just tell you, mRNA vaccine is a technology that has been used widely in the COVID-19 vaccine. Yes, you are correct. But let me just also correctly mention it here. This technology is not new. we knew about this technology. So I think just wanted to make sure that we instill that trust in the population that this is a mRNA vaccine that we are using is a new for COVID-19, but this is not a new technology. The other part is you talked about which part of the SARS-CoV-2 virus these vaccines work through. These vaccines are designed to target the spike protein of the SARS-CoV-2 virus, which then works through a process that mRNA, a portion of the virus and mRNA gets replicated, and it produces, when injected in a person's body, the antibody response, which then identifies this virus in future when it gets attacked. And then these antibodies then protect the person who receives, remember, the scheduled dose. If it is a 1 dose, then the person has to receive a dose. And if it's 2 doses, then the person needs to receive both the doses and then wait for between 17 to 14 days to generate that degree of antibody. The other part which you mentioned, I missed what, I did not get what part of CoronaVac that you were mentioning in the VAC vaccine. There are other technologies also being used. One is an inactivated vaccine, the other one which is an adenovirus-based vaccines. The safety efficacy are being all looked into by WHO within what we say emergency use listing. And this looks into the different safety and efficacy of the vaccine, irrespective of what technology is being used for developing this vaccine. And sorry that I missed some part of it, and happy to answer later through our communications team. Thank you so much.
Thanks, Siddhartha. And Ashwin, if you'd like to send us your question by email, we'd be happy to respond if there were parts that we missed, because it did break out a little bit, the connection. So on this note, let me thank everybody and close our press briefing today. It just remains for me to thank our guests, Mr. Richard Rools and Professor Martin McKee, our panelists, and thank you to the Regional Director, to Dr. Datta, Dr. Smallwood, and Dr. Pfeifer, and to all of those of you that have called in. We will be sharing both Dr. Kluge's statement, but also Professor McKee's statements by email, as well as posting them online on our website, and of course with a recording of the briefing online alongside it. Any additional questions, please follow up by email to us. We'd be very happy to respond to those. Suffice to say, as always, stay healthy, take care, and thank you once again for joining us today. Goodbye.